Hi, good morning. My name is Edwin Chandrasekhar. I'm with the Asian Health Coalition. And just a couple of housekeeping items. We have a full agenda today. And before I introduce our first speaker, Dr. An, just want to let you know, restrooms just past the elevator to your left. Please feel free to help yourself to the breakfast bar. They will replenish food until 10:30, at which time they will close it. And we will take a 15-minute break from 10:30 to 10:45. My understanding is if you need to use your cell phones, connection and the sound is not that great here, but apparently if you go closer to the windows, it's a little better, so try to figure that out. And we will have lunch, will be served at 12 o'clock. The Region 5 Director, Ken Munson, will be joining us, and he wants to deliver some remarks on behalf of Howard Co. about the Viral Hepatitis Action Plan and its implications for health reform. And in addition to that, let's see, CME credits are being offered. Just after lunch, we will have the forms distributed to those who actually want to claim the CME credits through the University of Chicago. And in terms of timing, because we have a packed agenda, for those of you that may have questions, please feel free to ask during the Q&A. If we do have to go over, we might stop you, but feel free to connect with the speakers and the panelists during the break and during lunch. And with that, I am actually going to start with the first presentation, which is on hepatitis B, viral hepatitis and liver cancer. Specifically, I would like to introduce Dr. Joe An, who is with the Loyola University Medical Center. He's the medical director for liver transplant. And Dr. An has been a friend of the coalition for many years. When he's not working, we drag him out to all the Asian Health Coalition events to do community education talks. So we've been very privileged that he's taken so much time out to support us. So Dr. An, thank you for doing that. And we can start with your presentation.
Well, thank you very much, Edwin, for that kind introduction. My name is Joseph An, and I'm sorry to confuse everybody with this switch in my background PowerPoint template, but I'm in transition between Loyola and the Oregon Health Science University. Again, I'm here to talk about hepatitis B and liver cancer with a focus on the Midwest and the Asian American population. And before I start, I'd like to thank Dr. Karen Kim and the Asian Health Coalition for this wonderful opportunity to be here today. I'm very honored to be amidst such a distinguished panel of speakers and invited guests. And this is a topic that's very near and dear to my heart in talking about hepatitis B. And as we talk about hepatitis B, I'd like to frame this in the context of what kind of faces does hepatitis B have to us in the community, in the healthcare world, and to the families that are afflicted by this disease. And as we'll go, I want to start very much at the basics, that it is a virus. And we'll look at some of the pictures of what this virus looks like. And then shift to how it has become the first recognized viral carcinogen. And then talk a little bit more about what I think is the focus of today's conference, which is its impact on disparities in the American population. And that despite all of some of the negative things that we'll see with regards to disparity, that this can be an opportunity, that hepatitis B can be a face of opportunity for us to get together, as the alderman has said, to group around this unique challenge that faces all the communities that are facing the impact of hepatitis B and liver cancer. So without further ado, I'll show that this is a virus. This slide usually puts our fellows to sleep when we show this in the medical school. And in the medical school classes, I know because I've shown this slide before to the second and third year students, and they start phasing away after looking at the 42 nanometers and the 22 nanometers. But what I'd like you to focus on is that this looks like such a very small and innocuous appearing, very small circle with a couple of dots. And you cannot see this in the naked eye. And that this is a particle that was a great challenge to discover, but that it has been discovered and identified, and that we have very good tests to detect these antigens and antibodies. But the point is that this phase of hepatitis B causes such great consternation and suffering to the whole world. And if we look at this from a global standpoint, one can see that this has indeed affected a large number of people, more than 2 billion to be exact. And of these people, more than 400 million have been chronically infected with hepatitis B. What this means is that at the conservative end, up to 500,000 to 1 million people worldwide are dying from complications of hepatitis B, which can include such things as cirrhosis, acute liver failure, and liver cancer, which we'll focus on today. And that this occurs in up to 25%. 1 out of 4 patients who are infected with this virus. Now, this is not just a global problem. It affects us in the United States. We're not protected by our borders or by the Pacific and Atlantic Ocean. In fact, that this is a disease that affects up to 2 million Americans at the conservative or midpoint end, and that this may comprise somewhere in the 5 to 10% of chronic liver diseases that affects Americans today. Oh, and a good note is that the incidence, that is the new cases of hepatitis B, has decreased over the last decade. And this can be attributed to the great work and efforts put in by the CDC as well as healthcare workers and providers such as you in terms of enforcing and looking at the vaccine usage, implementing the vaccine use, catch-up vaccines for adolescents, and making sure that Hep B infected women, children, are given appropriate immunoprophylaxis and vaccinations after birth. However, the prevalence in the United States, that is the number of cases, number of patients with hepatitis B in the US, has remained rather steady. And this has to do with the fact that there is the impact of immigration from patients who are coming from high endemicity countries, such that we have on the low end, the NHANES data from 2008 suggested that 0.3 to 0.4% of the population has hepatitis B. So you'll see a couple of numbers that are thrown out there throughout today in terms of who has hepatitis B. But some of the conservative numbers are plagued by the fact that those populations which are greatly afflicted out of proportion, such as those in homeless shelters, those who may have disputed legal status, those who are undocumented, were not necessarily counted in terms of seeing who has hepatitis B in the United States. In other words, we don't really have a great idea or very fine granular understanding of who has hepatitis B to the exact detail that we'd like. This is the other face of hepatitis B. It is a carcinogen, and this is a rather ugly picture. If you look to your left, this is hepatitis B associated liver cancer, and you can clearly see that this is a yellowish appearing mass that's arising out of the background of liver. And on the right, you can see a much more aggressive vascular invading liver cancer. What the point here is that hepatitis B leads to liver cancer, and of an interesting note is that up to 30% of these patients may not have cirrhosis when they present with liver cancer and hepatitis B. Thus, this is a very, very oncogenic virus. And in fact, the US Department of Health and Human Services reported in 2004, quote, hepatitis B virus is known to be a human carcinogen based on sufficient evidence from studies in humans. So this was the first virus declared to be etiologically related or causative of a cancer. Thus, I can say that hepatitis B is indeed a carcinogen. And in fact, as we've already heard, up to 80% of the liver cancers in the United States are due to a viral hepatitis. Dr. Rowe is going to talk about hepatitis C. And if you count Hep B and Hep C together, it comprises 4 out of 5 patients in the US who present with liver cancer. But in the world, more than 60 to 80% of people with liver cancer are having that due to hepatitis B. And you can see all the numbers here, and I'm not going to go into all the small details, but a 50 to 100-fold increased risk of liver cancer if you have hepatitis B versus if you don't have hepatitis B. Now, liver cancer in general is on the rise in the United States, and we can't blame that all on hepatitis B. Of course, we are seeing the aging population of hepatitis C patients as well as the impact of non-alcoholic steatohepatitis. But the data shows that this is rising for both men and women between the 2004 and 2008 figures. And if you look at the estimations of people who are supposed to have liver cancer in 2012, you can see that it has risen by nearly 2,000. It's the 9th leading cause of cancer mortality in the United States. And in the world, it's the 6th most common cancer and the 3rd leading cause of cancer mortality. In addition, this is a cancer that is not only rising, but it's a rapidly fatal cancer. And I'll show you the next graph, which I think illustrates this to much better detail. If you look to your left, you can see the estimated new cases of cancers in the United States in 2012. And even if you have to look very carefully, I've outlined for you in red where the liver and intrahepatic bile duct cancers are. And on the left, you cannot see liver cancers at all in terms of the estimated new cases. It does not make the top 10 in liver cancers for men and women. However, if you look to your right and look at the estimated deaths, you can see that it's in the top 5 for men as a cause of cancer-related death, and number 9 for women in the United States. What this is saying that out of those patients who get hepatocellular carcinoma, this tends to be a rapidly fatal cancer. And this is in contradistinction to something like prostate cancer, which is up here on the right. You can see that about 250,000 men were diagnosed with prostate cancer, but only about 28,000 patients will die in 2012 from prostate cancer. In other words, it is not as fatal of a cancer as liver cancer is. Now that we're in the Midwest Conference, I looked up some of the data for you, and we can see that in the Midwest here, we're somewhat in the middle in terms of incidence for liver cancer. Hawaii tops at about 19 patients per 100,000, and on the low end is if you don't want to have liver cancer, you should move to the Dakotas because there's only about 5 to 8 patients per 100,000 with liver cancer. But in the United States, and specifically in the Midwest, we are somewhere in the middle, just as we are geographically. And if you look at Illinois in particular, the data suggests that the historical trends from 1975 to 2008, that liver cancer is continuing to be on the rise. And this translates, as I'll get into cost as well as additional suffering for the patients and their families. Now that we've seen that hepatitis B is a carcinogen, the next logical step is, well, how can we prevent this virus, this carcinogen, from having its effect? Well, in 1982, the advent of the vaccine has made a significant impact on hepatitis B. However, there's still more work to go. This is the first anti-cancer vaccine that was created and provided, and it's been recommended to all infants and catch-up and those at-risk adults, patients who are on hemodialysis, for instance, those who are incarcerated, those are from high endemicity countries need to be tested and vaccinated. And I thought it was interesting to note that after tobacco, infection is the most preventable cause of cancer, and hepatitis B virus certainly falls into that category. And if you want to look at some of the impact that the vaccine has had, one has to turn our eyes onto the well-publicized impact on Taiwan. In July of 1984, the Taiwanese government implemented national testing and vaccination for infants. And before that, there was a case of up to 0.7 children per 100,000 having liver cancer between the ages of 6 to 14. And you can see the rates of hepatitis B surface antigen in the bluish color, and then the core positive, which is a marker of exposure, was significantly higher than what happened as soon as they implemented that. Within a 10 to 20 year period, you can see the dramatic drop in those who are chronically infected with hepatitis B, as well as those who are exposed. So it's beginning to have a herd immunity effect. However, there's still more work to be done because, unfortunately, despite this, little children are still getting infected with hepatitis B, as well as having complications of cirrhosis and hepatocellular carcinoma. Now, as a hepatologist, one of the things that I really think is very important is that if you have hepatitis B and if you haven't been able to prevent it and the patient shows up to you with the diagnosis and infection of hepatitis B, one of the most important things is to recognize that because of the increased risk of hepatocellular carcinoma, one has to be vigilant about the risk and development of liver cancer. And it's important, I think, to recognize why early surveillance and catching liver cancer when it's very small is very important. It's because if you have somebody with a large cancer, more than 5 centimeters or larger, the prognosis is unfortunately rather dismal. And this becomes worse if that person has vascular invasion of any of the veins around the liver, or it has spread outside the liver to the bones or to the lungs. In addition, smaller lesions, that is a small lesion less than 5 centimeters or up to 3 spots less than 3 centimeters each, do receive preferential priority for liver transplantation. And they can be cured with a success rate of 1 year 90% survival and 5 years 70% survival. In addition, there's a very large randomized controlled trial from China, which, although it has been criticized for some methodologic issues, has shown that when they took these 19,000 patients, they gave half of them ultrasound screening and the other half didn't get screening, there was a dramatic impact on what happened to these people. You can see that 37% reduction in liver cancer-related mortality occurred in those who were lucky enough to receive screening. And that's despite not everybody listening to their doctors or following up. Only 60% of them did that. In other words, if more of them had been adherent, you might have even seen a greater reduction in the cancer-related deaths. Now, this is something that Dr. Ray Kim will talk about later on in the morning, so I'm not going to say more, except to point out that hepatitis B continues to be a leading carcinogen, despite the fact that we have 7 FDA-approved drugs. And it's not that we don't have good drugs that work and are safe, it's that if you look at this one study that came out from Cohen et al. Last year, if you look from those who are on your left, starting at about, let's say, 2 million estimated, you look at those who are entering care, those who are aware and entering care, and those who are finally prescribed a hepatitis B drug, it's a very small percentage of people who are receiving drugs based on this investigator's review of the FDA database on Hep B prescriptions. In other words, we need to do a better job. So Hep B remains a leading carcinogen in the world. It is one of the leading infectious carcinogens in the United States, despite the fact that, as I've shown you, it's preventable. A vaccine has been available since 1982. That's 30 years ago. It's diagnosable. You have widespread availability of hepatitis B surface antigen testing. Imaging is widely available for looking for liver cancer with an ultrasound. It's treatable with 7 FDA-available therapies. And there's a randomized controlled trials that show that treatment improves survival. And I don't have time to go into the impact of discussing some of the data with you with regards to the impact of treatment on reducing liver cancer. There's a lot of intriguing data from Asia that suggests that lower hepatitis B levels in the blood will translate into lower risk of liver cancer. Nevertheless, we still need to do a better job, is the message that I take away on review of hepatitis B and liver cancer. The third phase, as we switch gears a little bit, is that hepatitis B is a face of disparity. The Institute of Medicine of the National Academies reported that Asian and Pacific Islanders comprise more than 50% of Americans who are living with hepatitis B right now. And in fact, if you look at some specific studies and populations, such as the Chinese in San Francisco, the immigrant population in New York, in some of these subpopulations, minority populations, the prevalence is as high as 1 out of 7 people who have hepatitis B in those minority populations. And what I think is more tragic is that because hepatitis B is asymptomatic to a large degree for a long period of time, more than 2/3 of those who are infected are not aware of their status. And thus, they are perpetuating through vertical transmission to the next generation of this hepatitis B virus from one generation to another. And that's an unfortunate cultural and as well as population sorrow that this keeps getting passed on due to ignorance. If you look at the SEER, that is a Surveillance and End Epidemiology Results Cancer Statistics Review from 2004 to 2008, you can see that what I've highlighted in bold is the Asian American Pacific Islander population. And you can see that it is nearly 2-fold higher compared to all races in general. And if you look at the Caucasian population, it's 22 per 100,000 for men compared to 9.6. I think those numbers tell you that this liver cancer impact is greater in the Asian American population. And if you look at this study, which came out from California, I like this study because of 2 things. One, it shows that liver cancer rates are almost 3 times higher in the Asian American population than in the Caucasian population. But the other point I like to point out is that the Asian American population is not a homogeneous single population. That even within the Asian American population, there are various specific ethnicities and races which have their attendant different risks as well as the incidence and mortality rates. For instance, a Vietnamese male has a higher risk than someone who's of Japanese American descent with regards to the incidence and mortality due to liver cancer. And as we look at this map of Illinois, I had confessed that I had to look up where Springfield and Peoria was in order to correlate to what the numbers are there. But on the red, which is an area of highest liver cancer incidence, that's where we are in Chicago and Cook County. And if you look at on the right, that area of, let me see, Champaign is, Springfield, I think, is right here, and then Peoria is right here, and then Champaign is right there. So these are areas of higher graduate students from foreign countries, and I think that kind of suggests the pattern of liver cancer in Illinois, at least. So hepatitis B remains a source of disparity and also its impact on liver cancer. And Asian Americans are the only group for which cancer in general remains one of the leading causes of death in the United States. In addition, I think this is due to a lack of awareness. There are many misconceptions when I go and speak with community groups and field questions from community members. You have the whole gamut of questions and myths about hepatitis B, hepatitis C, and liver cancer. In addition, unfortunately, there's still a lack of funding, and there's underutilization of diagnostic testing by physicians and providers to test the appropriate groups for hepatitis B. In addition, not only do you have a problem with diagnosing people, but there's an issue of linkage to care, of connecting people who have this virus to the appropriate follow-up care that they need. And there's still a need for further education for the community, for healthcare providers, because unfortunately, we still have failures in our system to appropriately immunoprophylax children who are born to hepatitis B infected mothers. Within 12 hours of their birth, they should be receiving a vaccine and Hep B immunoglobulin on alternate arms. So there's still more work to be done. And as I finish, unfortunately, I have to point out that at this point, the face of hepatitis B has led to Asian Americans remaining underinformed about this disease, under-tested with testing for hepatitis B and liver cancer, and still underprotected. And what this does is that it has consequences. And these are the patients and their families that I see every day, where they come in with their father who has a very large liver cancer that is unfortunately beyond repair or operable. And that person has a less than 1 year survival. Not only do you have personal losses and their families' loss, this has led to the impact on increasing healthcare costs. This is a study from Dr. Ray Kim, who's going to be presenting later on this morning, but he looked at the Hep B-related hospital charges from 1996 to 2006. And you can see that the charges are not going down per se. The trend is going up. Not only that, this does not take into account all of the potential earnings and all the potential losses that the families will have as a result of this person's untimely demise. So I've gone over the fact that hepatitis B is a virus, that it is a carcinogen, that unfortunately it is a face of disparity. But on a hopeful note, I believe that hepatitis B can be an opportunity for us to come together as multiple communities from different backgrounds, that it's a uniform enemy for us because it's a cause of death and disparity for all people. Liver cancer incidence is trending up for all races in the United States. It does not discriminate, it does not pick out, it's fatal. This is something that we have many tools available with regards to education, vaccination, screening, as well as treatment. And my hope is that this Midwest Viral Hepatitis Conference can be another step toward transforming the face of hepatitis B and liver cancer to be one of opportunity and unity. Thank you very much.